Hello guys, it's me again, Nurse Clari, and in this video I'm going to discuss about the neuronursing assessment. So let's start this discussion with this question. A patient arrived at the emergency room from motor vehicular accident is only responding to painful stimuli by opening his eyes and by withdrawing from it. He is only mumbling sounds. So what is the GCS score of this patient? So number 1, eye response is 2, verbal response 2, motor response 3, total GCS is 7. Number 2, eye response 2, verbal response 3, motor response 4 with a total of 9. Number 3, eye response 1, verbal response 3, motor response 3 with a total of GCS 7. Number 4, eye response 2, verbal response 2, motor response 4 with a total GCS of 8. So let's answer this question as we move on or after the discussion of the neuronursing assessment. So let's now define neurological examination. The neurological examination is an assessment tool to determine a patient's neurologic function. It is beneficial in a variety of ways as it allows the localization of neurologic diseases and helps in ruling in or ruling out differential diagnosis. Neurologic assessment doesn't just take place in neuro units and the emergency department. A patient who doesn't have a neurologic diagnosis may also require a neuro assessment. For example, a patient with pneumonia can develop neurologic changes due to hypoxia, or a post-op patient may have a neurologic deficit due to blood loss. No matter what setting you work in, you'll have to perform a neurologic assessment at some point. The value of a solid neurologic assessment can't be overstated. A small change in the assessment is indicative of a neurologic injury, and early intervention can prevent permanent damage. So, the comprehensive assessment, a thorough neurologic assessment will include assessing mental status, cranial nerves, motor and sensory function, pupillary response, reflexes, the cerebellum, and vital signs. However, unless you work in a neuro unit, you won't typically need to perform a sensory and cerebellar assessment. Also, most vital sign changes are a sign of end-stage neurologic injury. Now, let's start with the mental status. So, how do we assess our patient's mental status? Of course, that is the level of consciousness of our patients. It is the most important aspect of the neuro exam, or should I say, the most sensitive indicator of neuro status. So, how do we assess the level of consciousness of our patient? Of course, we need to know if the patient is oriented to person, time, place, and surroundings. But first, we need to know if the patient is alert. That's the time that we check if the patient is oriented to person, time, place, and surroundings. And lastly, we need to check the short-term and long-term memory of our patient. Let's now discuss the terminology of level of consciousness. So full consciousness, when you say full consciousness, patient is alert, attentive, and follows commands. If asleep, responds promptly to external stimulation, and once awake, remains attentive. Lethargic. Patient is drowsy but awakens, although not fully, to stimulation, will answer questions and follow commands but slowly and inattentively. Obtunded. Patient is difficult to arouse and needs constant stimulation in order to follow a simple command. May respond verbally with 1 or 2 words but will drift back to sleep between stimulation. Stuporous. Patient arouses to vigorous and continuous stimulation. Typically, a painful stimulus is required. May moan briefly but doesn't follow commands. Only response may be an attempt to withdraw from or remove the painful stimulus. Comatose. Patient does not respond to continuous or painful stimulation, does not move except passively, reflexively, and does not make any verbal sounds. Remember that recognizing and describing a change in LOC or level of consciousness is more important than appropriately naming it. So right now, let's discuss about the Glasgow Coma Scale. Glasgow Coma Scale is the most common scoring system used to describe the level of consciousness in a person following a traumatic brain injury. Basically, it is used to help gauge the severity of an acute brain injury. The test is simple, reliable, and correlates well with outcome following severe brain injury. So there are three things that we test. Those are the eye-opening, motor response, and verbal response. When you say spontaneously, that is score number 4, opens eyes spontaneously. Opens eyes to verbal command is 3, while opens eyes to painful stimulus is 2. Doesn't open eyes in response to stimulus is 1. Under motor response, reacts to verbal command or obeys verbal command, that's number 6. Identifies localized pain, that's 5. Flexes and withdraws from painful stimulus, that's 4. Assumes a decorticate position, that's 3. Assumes a decerebrate position, that's 2. 1 is no response or lies flaccid. While verbal response is oriented and converses, that's 5. Disoriented and confused, that's 4. Replies randomly with incorrect words, that's 3. Moans or screams, that's 2. And no response is 1. So individual elements as well as the sum of the score are important. The individual elements of a patient's GCS can be documented numerically. For example, E2, V4, M6, as well as added together to give a total Glasgow Coma score of 12. And of course, every brain injury is different, but generally, brain injury is classified as GCS 13 to 15 is mild head injury, GCS 9 to 12 is moderate head injury, while GCS 3 to 8 is severe head injury. While this is the Glasgow Coma Scale for pedia. Eye-opening, so that would be 4 for spontaneous, 3 to voice, 2 to pressure, 1 none, and NT not testable. Verbal response, 5 smells oriented to sounds, follows objects, interacts, 4 cries but consolable inappropriate interactions, 3 inconsistently inconsolable moaning, 2 inconsolable agitated, 1 none, NT not testable. Motor response, 6 moves spontaneously or purposefully, 5 localizing or withdraws from touch, 4 normal flexion withdraws to pain, 3 abnormal flexion decorticate response, 2 extension decerebrate response, 1 non-NT not testable. And pediatric brain injuries are classified by severity using the same scoring levels as adults. GCS 13 to 15 is mild head injury, GCS 9 to 12 is moderate head injury, and GCS 3 to 8 is severe head injury. Now let's go to pupillary response. So, pupillary response is assessment of pupils. Is especially important in a patient with impaired LOC or level of consciousness. Similar to change in LOC, change in pupil size, shape, or or reactivity can indicate increasing intracranial pressure from a mass or fluid. Pupils will be covered as part of cranial nerve assessment. So evaluation of pupillary reaction is effectively an assessment of the third cranial nerve or oculomotor nerve, which controls constriction of the pupil. Compression of this nerve will result in fixed dilated pupils. So performing the exam for pupillary responses. When performing a pupillary exam, it sometimes helps to illuminate pupils indirectly from the side so you can actually see what is happening. So number 1, observe the pupil size and shape at rest, looking for anisocoria, one pupil larger than the other. It means anisocoria refers to the asymmetric sizes of pupils. Number 2, observe the direct response, constriction of the illuminated pupil. 3. Observe the consensual response, constriction of the opposite pupil. 4. Repeat with the opposite pupil. And 5. Check for accommodation, constriction of pupil when viewing a close object. So this is the anisocoria and the strabismus. Anisocoria, like what I said earlier, it refers to the asymmetric sizes of pupils. While when you say strabismus, it is a condition in which the eyes do not properly align with each other when looking at an object. So the normal response of our eyes is pupils equal, round, reactive to light, and accommodation, while the abnormal response are not of equal size, not reactive to light, not round, and not accommodating to focus on objects near or far. So grading pupil size. To accurately evaluate pupil size, compare the patient's pupils with the scale shown here. Keep in mind that the maximum constriction may be less than 1 mm and the maximum dilation greater than 9 mm. Assessing for signs of motor dysfunction. So once we assess that, patient must be awake, willing to cooperate, and able to understand what you are asking. With patient in bed, assess motor strength bilaterally. Have the patient flex and extend arms against your hand, squeeze your fingers, lift leg while you press down on thigh. Hold legs straight and lift against gravity. Flex and extend foot against your hand. If motor function is intact, muscles can be moved to command. Symmetrical movement and strength is one of the most important assessment findings. Reduced motor function can occur as a result of injury to the cerebral cortex, motor pathway, peripheral nerve, or muscle. While it takes a certain level of function to move a muscle to command, increased innervation and muscle strength is required to overcome gravity. Even greater strength is required to overcome resistance by an examiner. Assessment of motor function can be graded in patients able to obey commands as follows, right compared to left. So 5, normal strength able to maintain the muscle contraction against examiner resistance. 4, mild weakness, weakly or briefly able to overcome examiner resistance. 3, able to support the limb against resistance but unable to overcome examiner resistance. 2, can move the limb but unable to lift against gravity. 1, flicker but no movement. 0, no movement. Now, assessing for signs of motor dysfunction. Unconscious patient. Assess motor response in unconscious patient by applying a nauseous stimulus and observing patient's response. Another approach is central stimulation, such as external pressure, produces an overall body response. It is actually more reliable than peripheral stimulation. So why is it more reliable? In an unconscious patient, peripheral stimulation such as nail bed pressure can elicit a reflex response, which is not a true indicator of motor activity. So now let's evaluate sensation. Evaluating sensation. So patient must be able to cooperate with the exam. We'll need to tell you whether the sensation is felt and whether it is felt on both sides of body equally. So you will begin with the feet and move up the body to the face, comparing one side with the other. As a sensation to light touch using your fingertips or cotton. Test superficial pain sensation with a clean unused safety pin. Also, test sensation using a dull object. The patient should be able to distinguish sharp from dull. Test proprioception or position sense by moving the patient's toes and fingers up or down. Grasp the digit by its sides and have the patient tell you which way it's pointing. So actually, this sensory examination is used to determine areas of abnormal sensation, the severity and type of sensory impairment, and the extent of the involvement. One of the principal goals of the sensory exam is to identify meaningful patterns of sensory loss. Basic testings should sample the major functional subdivisions of the sensory systems. The patient's eyes should be closed throughout the sensory examination. So let's now move on to evaluating cerebellar function. Test if indicated. However, testing cerebellar function may not be necessary in a problem-focused exam and cannot be performed if patient can't or won't follow commands. So for the upper extremities, if patient is in bed, hold up your finger and have patient quickly and repeatedly move his finger back and forth from your finger to his nose. Then have patient alternately touch their nose with their right and left index fingers. Finally, have patient repeat these tasks with their eyes closed. Movements should be precise and smooth. So for the lower extremities, have patient bend their leg and slide that heel along the opposite shin from the knee to the ankle. This movement, too, should be accurate, smooth, and without tremors. If patient is able to stand, you can assess their balance using this Romberg test. Have patients stand with their feet together, arms at their sides, and eyes open. He should be able to stand upright with no swaying. If he can do that, have him close his eyes and stand the same way. If he falls or breaks his stance after closing his eyes, the Romberg test is positive, indicating proprioceptive or vestibular dysfunction. Right now, let's go to assessing deep tendon reflexes. Deep tendon reflexes include triceps, biceps, brachioradialis, patellar, Achilles tendon. So these are not routinely assessed. Okay? Should be tested in any patient with a spinal cord injury, tested with reflex hammer. So deep tendon reflexes grading 4+ means very brisk, hyperactive with clonus. 3+ brisker than average, slightly hyperreflexive. 2+ average, expected response normal. 1 plus somewhat diminished, low normal. 0, no response or absent. So what we need is 2 plus, that's the normal. So deep tendon reflexes for the biceps, patient's arm should be flexed slightly with the palm facing up. Hold arm with your thumb in the antecubital space over the biceps tendon. Strike your thumb with the hammer. The arm should flex slightly. Triceps. Patient's arm should be flexed 90 degrees. Support the arm and strike it just above the elbow, between the epicondyles. The arm should extend at the elbow. Brachioradialis. Patient's arm should be flexed slightly and resting on the lap with the palm facing down. Strike the outer forearm about 2 inches above the wrist. The palm should turn upward as the forearm rotates laterally. Patellar. With the patient's legs dangling if possible, place your hand on one thigh and strike the leg just below the kneecap. The leg should extend at the knee. Achilles tendon. With patient's foot in slight dorsiflexion, lightly strike the back of the ankle just above the heel. The foot should plantar flex. Assessing superficial reflexes. Plantar reflex is the only superficial reflex that's commonly assessed and should be tested in comatose patients and those with suspected injury to lumbar 5-5 or sacral 1-2 areas of the spinal cord. Stimulate the sole of the foot with a tongue blade or the handle of a reflex hammer. Begin at the heel and move up the foot in a continuous motion along the outer aspect of the sole and then across the ball to the base of the big toe. Normal response is plantar flexion, curling under of the toes. Extension of the big toe, or what you call Babinski's sign, is abnormal, except in children younger than 2 years old. Let's now discuss the cranial nerves. 12 pairs of cranial nerves. We do have sensory, motor, and both. So those are the functions. Assessment of which nerves depends on patient's diagnosis, must have patient cooperation, cannot perform complete assessment on comatose patient. Extraocular movements, or EOMs, are controlled by cranial nerves 3, 4, and 6, which you'll test together. Other functions that are dependent on more than one cranial nerve are pupillary response, which is CN, or cranial nerve 2 and 3, corneal reflex, cranial nerves 5 and 7, and gag reflex, cranial nerve 9 and 10. So, olfactory, or cranial nerve 1, that's sensory, so smell. Have patient identify a familiar scent with eyes closed, usually deferred, but one nose at a time, so the right and the left. So number 2, optic, sensory, vision, acuity and field of vision, pupil reactivity to light and accommodation, afferent impulse. Have patient read from a card or newspaper, one eye at a time. Test visual fields by having patient cover one eye, focus on your nose, and identify the number of fingers you're holding up in each of 4 visual quadrants. You can also use here the Snellen chart for distance vision. So number 3, oculomotor, or for motor function, eyelid elevation, most EOMs, pupil size and reactivity, efferent impulse. Check pupillary responses by shining a bright light on one pupil. Both pupils should constrict. Do the same for other eye. To check accommodation, move your finger toward the patient's nose. The pupils should constrict and converge. Check EOMs by having patient look up, down, laterally, and diagonally. 4. Cranial nerve 4 is trochlear, which is for motor. EOM turns eye downward and laterally. Have patient look down and in. 5 for the trigeminal or both, that's sensory and motor. Chewing, facial and mouth sensation, corneal reflex, which is sensory. Ask patient to hold the mouth open while you try to close it and move the jaw laterally against your hand. With patient's eyes closed, touch her face with cotton and have her identify the area touched. In comatose patients, brush the cornea with a wisp of cotton. The patient should blink. Abducens. Cranial nerve 6, which is motor functions. EOM turns eye laterally. Have patient move the eyes from side to side. Cranial nerve 7, which is facial. That is both. So sensory on motor. Facial expression, taste, corneal reflex or motor, eyelid and lip closure. Ask patient to smile, raise eyebrows, and keep eyes and lips closed while you try to open them. Have patient identify salt or sugar placed on the tongue. Next is cranial nerve 8, which is acoustic or vestibulocochlear. So that's sensory. Hearing equilibrium. To test hearing, use tuning fork or rub your fingers. Place a ticking watch or whisper near each ear. Equilibrium testing is usually deferred. So 9 is glossopharyngeal, which is for both sensory and motor, gagging and swallowing, and of course taste. Touch back of throat with sterile tongue depressor or cotton tip applicator. Have patient swallow. Then vagus nerve, which is cranial nerve 10, which is also both sensory and motor, gagging and swallowing, and speech. Assess gag and swallowing with cranial nerve 9. Assess vocal quality. Cranial nerve 11 is spinal accessory, which is motor, shoulder movement, head rotation. Have patient shrug shoulders and turn head from side to side. And of course, cranial nerve 12, which is hypoglossal, motor, tongue movement, speech, so articulation. Have patient stick out tongue and move it internally from cheek to cheek. Assess articulation. So a quick recap on what we have discussed. So for the neuronursing assessment, we have discussed the mental status or the level of consciousness. Level of consciousness that can be assessed by checking if the patient is alert, and of course checking if the patient is oriented to person, time, place, and surroundings, and lastly by checking the short and long-term memory of the patient. And also we discuss also about the full consciousness, lethargic, obtunded, stuporous, and comatose. And of course, when it comes to the most scoring system to describe level of consciousness, we do have the Glasgow-Coma scale, which I actually memorized. I just think that they are divided into 3 categories, which are eye response, verbal response, motor response, and then I always remember that 1 means no response. So for the eye, 1 no response, 2 to pain, 3 to sound or speech, 4 is spontaneously. For the verbal response, 1 no response, 2 incomprehensible, 3 inappropriate, 4 confused, and 5 oriented. While for the motor response, 1 no response, 2 decerebrate, which is abnormal extension, 3 is decorticate, which is abnormal flexion, and I always remember the decorticate for number 3, that number 3 is decorticate. and then 4 withdraws from pain, and then 5 localized pain, and lastly obeys command. So that would be 4, 5, and 6. And of course, we also discuss about the papillary response, wherein a change of the pupil size, shape, and reactivity could indicate an increased intracranial pressure from a mass or fluid. And what is very important here is to get a perla, which is the normal response for the pupillary response, which is pupils are equal, round, reactive to light, and accommodation. And of course, we also have the motor dysfunction. And for the motor dysfunction, it is very important to remember the grading system, like 5 for the normal strength, 4 for the mild weakness, 3 able to support the limb against resistance, 2 can move the limb but unable to lift against resistance, 1 is for the flicker but no movement, 0 no movement at all. And of course the cerebellum and the reflexes, which we don't actually mostly use when we are working. So, but what's very important is to know the deep tendon reflexes and the grading system, that we need to remember the 2 plus, which is normal, or that is the expected response, because we are going to see those reflexes or those numbers on some of the questions, sample questions of NCLEX-RN examination. So 4 plus for the hyperactive, 3 plus is slightly hyperactive, 2 plus is the normal or the expected response, and that's what we want to have. 1 plus, of course, is diminished, 0 is absent. And of course, we also discuss about the cranial nerves, wherein we just need to remember that cranial nerves 3, 4, and 6 are tested together for the extraocular movement, and then pupillary response, checking the cranial nerve 2 and 3, corneal reflex, cranial nerve 5 and 7, and gag reflex, cranial nerve 9 and 10. They are tested together. So of course we also have our vital signs. Vital signs is divided into 5, but we did not discuss that earlier, but we already know this as a nurse. So vital signs are composed of body temperature, pulse rate, respiratory rate, blood pressure, and of course the 5th vital sign is pain. And before I forgot, always remember also the Babinski sign. Babinski sign is an abnormal sign, and you can only it is only normal with the newborn or children below 2 years old. But if your child is able to walk already, Babinski sign should not be present. And the purpose of a neurological assessment is to detect neurological injury in your patient. So we need to monitor the progression to determine the type of care that we're going to provide and gauge the response to the intervention. Question. A patient arrived at the emergency room from motor vehicular accident, is only responding to painful stimuli by opening his eyes and by withdrawing from it. He is only mumbling sounds. What is the GCS score of this patient? So let's answer this question. Number 1, eye response 2, verbal response 2, motor response 3, and total GCS is 7. 2, eye response 2, verbal response 3, motor response 4, total GCS is 9. 3 is eye response 1, verbal 7, and 4, eye response 2, verbal response 2, motor response 4, with a total GCS 8. So let's go back to the chart of the GCS. So eye opening, it says in the question, only responding to painful stimuli by opening his eyes. So that's 2. So eye opening is 2. So we remove already number 3 because E2 is the answer. Then for the for the motor response, by withdrawing from it, it means withdrawing from painful stimulus. So that would be 4. So motor response 4. So we will eliminate 1. So we only have 2 and 4. For the verbal response, he is only mumbling sounds. So it means moans or screams that would be incomprehensible. So that would be 2. So the answer is I response 2, verbal response 2, motor response 4, with a total GCS of 8, which is a severe head injury. So that would be all about the neuronursing assessment. If you would ask me if I memorized the GCS scoring, of course I did. So on my next video, I'll be discussing the nervous system injury. Okay, so see you guys and thank you for watching.